Hello, good afternoon, everybody. I think we can probably start now. We've got quite a few people in already. Thank you so much. And please do keep introducing yourselves in the chat. It's lovely to see where everybody is coming from and what your interests are. So my name is Laila Adwan Kamara, and I'm the team leader on this program, Ghana Somubi Dwumadie, which also means Ghana Participation Program. And I'm just really delighted to welcome everybody today on behalf of the program. And it's just really exciting to be able to introduce this webinar. It's a really interesting, perhaps for some people a little niche, but we think a really critical topic, which is really going to be looking at today what the experience was in Ghana in terms of addressing key barriers to psychotropic medicines and really looking at the supply chain and also how to make psychotropics more accessible. So I'm just going to do a tiny bit of housekeeping before I hand over to our moderator and our speaker today. So just so you know, we have closed captions available for you, if that just helps in terms of hearing the presentation and all of that. So in your bottom toolbar at the bottom of Zoom, you'll see a little icon which says CC, show captions. And if you click on that, you'll be able to get subtitling essentially in English come up along the bottom of the screen, if that's helpful for you. And just to let you know that we don't allow AI tools within the system. They don't really work with Zoom. So please do use the closed captions rather than trying to use your AI tools. And then just in terms of the chat and then how to submit a question. So as we've already said, we're really happy to hear from you in the chat. We want to know who's in the room. Please introduce yourselves to each other. Tell us what your interests are. I'm sure some of you will find familiar names in the chat. And you do that just by clicking again in the bottom toolbar of Zoom. There's a little single speech bubble. It says chat, and you can just click on that and type away, and we're happy to hear from you. And also you can alert us to any technical issues in that chat function. But if you have a question specifically for the speaker or the moderator, please do use the Q&A function. This is just because it's a lot easier for them to see your question. It won't get missed, much more likely to get answered. And that's the little icon which says Q&A, and it has two little speech bubbles above it. And in there you can submit your question, and then we'll either answer that verbally or we might type you an answer as well, depending on how time is going. Okay, so that's all of the housekeeping done. So then it's really my pleasure to be able to introduce today's moderator to you. And today's moderator is Ms. Fidelicia Bakobier. And we've worked very closely together over a number of years. She is the head of pharmacy division at the Mental Health Authority and has oversight responsibility for the management of all centrally government procured psychotropic medicines for use in Ghana. And she's worked as the head of pharmacy in several health facilities as well, where she was responsible for the efficient and effective day-to-day management of the pharmacy unit of that facility, as well as ensuring the availability of essential medicines in various health facilities. So absolutely critical person to have had on board as a partner in the work that we've done together. And Fidelicia, it's just been such a delight working with you over the years. And I'm really happy now to be able to hand over to you as moderator. The rest of the webinar is now in your very, very capable hands. Thank you so much.
Thank you very much, Laila, and thank you for all the housekeeping you have done. It's been exciting working with you as well over the years on psychotropic medicine access. Good afternoon and welcome everyone to this webinar jointly organized by the Mental Health Authority of Ghana and the Ghana Somubi Dwumadie. We'll be looking at addressing key barriers to psychotropic medicine access and the Ghana experience. This webinar is actually a representation of 4 years' work that has been carried out. And the Mental Health Authority of Ghana was established by an Act of Parliament, the Mental Health Act 2012, and among its mandate is to promote mental health and provide humane care, including treatment and rehabilitation. Now, for treatment of mental disorders, we know that psychotropic medicines are an essential component of the psychosocial interventions that are used to manage these mental disorders. And as such, since Mental Health Authority is responsible for treating mental disorders in the country, making the psychotropic medicines accessible is a priority of the authority. But what we realize is that access and psychotropic medicines have not been available. They've always been erratic supply. There were frequent shortages and not accessible at the service delivery points. Now, since the Mental Health Authorities is actually interested in making care available to people near where they stay, community-based care, making the medicines available at the service delivery points is very important. So to better understand some of the problems that led to some of these, the problems that are making the medicines inaccessible, the Mental Health Authority partnered with Ghana Somubi Dwumadie, Lila and her team, to better understand these barriers. Now, Somubi supported us by providing a consultant who is a psychiatrist and has experience in the selection of psychotropic medicines. Our consultant joined the Mental Health Authority, or worked with the Mental Health Authority from 2020 to 2024. And actually, that consultant will be our main presenter today. She is a psychiatrist. Our presenter today is a psychiatrist, Adjunct Professor Leslie Robertson, who is jointly appointed Adjunct Professor in the Department of Psychiatry at the University of Wits, South Africa, and also the head of the psychiatry unit in the Sedinburg District Specialist Mental Health Team in Gauteng Province of South Africa. She works to advance person-centered, community-based psychiatry and integrated primary mental health care and a lay society which is supportive of people with serious mental health conditions. As a member of the South African National Essential Medicines List Committee, she supports the National Department of Health in selecting medicines for the public sector and the drafting of national standard treatment guidelines. Her research interest is in the field of public health. Please join me welcome Adjunct Professor Leslie Robertson. Leslie, we'll be glad to hear what you have been able to accomplish. Thank you.
Thank you very much, Federica and Lila, and thank you very much, everybody, for joining us this afternoon. So we'll be talking about addressing the barriers to psychotropic medicines and the Ghanaian experience. I shall just touch on why psychotropic medicines are essential medicines, the approach to the Ghanaian experience that we took, the actual coverage obtained for 2022 and compared to the population in need, tackling some difficult questions and implications of National Health Insurance Scheme inclusion of mental health conditions. So just to start with, Essential medicines, as we know, are medicines which need to be made universally accessible in an equitable fashion for those who need them, so that they can improve and to provide quality of care. So essential psychotropic medicines would enable a rights-based mental health care in the least restrictive environment for people with severe mental health conditions. In other words, universal health coverage for people with severe conditions being the conditions which are most amenable to medicine or treatment, and in fact very often dependent on judicious medicine treatment. Making them essential helps to reduce the stigma associated with psychotropic medicines, as well as the stigma and disability associated with the conditions themselves. And that is twofold. That is partly from the reduction of the impairment related to the illnesses, as well as the reduction of the disability related to the inaccessibility of care for people with these kind of conditions. And then finally, it facilitates outcome-oriented judicious medicine use, as it allows for monitoring and evaluation of the treatment and greater understanding of what we're actually doing with the medicines that we prescribe, and whether we're benefiting or not the person who we're giving them to, and where's the need for quality improvement. So to approach the Ghana experience, we used the 4x4 framework as a springboard, really, as a starting point that is outlined in this article by Barbara Retail. So this framework highlights 4 access components to medicines, and the first is the selection of medicines, the affordability, their availability, and appropriate use. So we started, before we started with the selection, the methods that we used were to analyze the situation, prioritize the issues through a review of the legislation and policy. And this was in 2020, so it was the legislation policy at that time. We conducted 2 stakeholder workshops in understanding the situation, the first in December 2020 and the second a year later in 2021. And we conducted a survey of stakeholders on their perceptions of the problem. And then we had virtual discussions, we wrote reports which were reflected upon by the Ghanaian specialists and the Mental Health Authority and stakeholders, and sharing of information between themselves and myself in South Africa. So the method here was really to understand what was happening and then to support the Ghanaian expertise and to integrate with the internal processes which were already taking place. We conducted 2 workshops in 2023, both in March, and then 2 in 2024, 1 in July and 1 in August. So in terms of medicine selection, that is determined largely by the standard treatment guidelines. In Ghana was already on their 7th edition of standard treatment guidelines. It was the 2017 edition, in fact, in 2020, and I think it was coming up for review. So they had a set of clear criteria for medicine selection. They had a very comprehensive mental health chapter in the guidelines and quite a wide range of psychotropic medicines, which are thereby considered as essential because they're in the guidelines. However, the actual medicines procured were not influenced so much by the guidelines as by the industry interest in the medicine procurement process and their capacity to supply, and the cost and the quality of the available medicines. So the range of medicines procured differed from the range of medicines in the standard treatment guidelines. and could vary from year to year. And the financing influences very much to affordability is related both to the costing of the medicine and the financing of the health system, and in the case of psychotropic medicines, of the financing of psychotropic medicines. And the most important thing that we found in Ghana is that mental health is not covered by the National Health Insurance Scheme. And the reason that it was not covered was because the mental health legislation had stated that mental health care should be free of charge to the user at the point of service. And this was perceived to mean that there should be some other supplier of the service or funder of the service, and the National Health Insurance Scheme cannot fund a service which has another funder. However, people with mental disability are registered with the National Health Insurance Scheme for other health benefits and do access the other health benefits through that scheme. And there is no other funder for psychotropic medicines or mental health services. There's no donor funder for these products. And so what was happening was that the Ministry of Health had to allocate an amount of money, a budget for psychotropic medicines every year. That allocation was taken out of the money that would be allocated to special programs. So mental health was being treated or managed as a special program. This budget, which would be allocated for psychotropic medicines, was allocated at the discretion of the Minister of Health and would be made available to the Mental Health Authority, who would then work on the procurement of medicines. So what we found is that we had a parallel discretionary financing process for psychotropic medicines compared to other essential medicines which would be procured for the National Health Insurance Scheme. And this led to quite a high degree of unpredictability regarding both the quantities and the range of medicines which were procured. It also meant that the psychotropic medicines were not included in the essential medicine procurement cycle. So the procurement, because it's dependent on the annual budget allocation, would happen at different times of the year to the essential medicine procurement. So the essential medicine procurement cycle is the procurement cycle that's used for medicines which would be reimbursed by National Health Insurance Scheme, and the forecasting and quantities would be informed by the claims and reimbursements made under the National Health Insurance Scheme. Here, it depended on the annual budget allocation. That was often delayed. The actual budget would be promised, but the transfer of funds would be delayed, meaning that the tender process would be delayed. And because it depended on the budget, the quantities procured were determined not so much by the utilization as by the actual money allocated for them. This then resulted in a parallel supply chain process. So with some integration, such as at regional medicine stores, but then to get from regional medicine stores through to facilities, very often managed by mental health coordinators and nurses at district level rather than pharmacists. So we found that the procurement and supply chain was poorly coordinated and that there was an inequitable distribution of medicines. Mental health care system itself also speaks to the availability of the medicines. So what is important in Ghana is that there is progressive rights-based legislation. So the system of mental health care means that the medicines and services should be available at the level of the community, close to the person's home. In addition to that, mental health was included in the National Healthcare Quality Strategy and in the National Health Policy in equity with other health conditions. However, there was some misalignment in that the National Community-Based Health Planning and Services policy did not include mental health care in its policy directives. And then the standard treatment guidelines, the mental health care chapter itself, restricted the prescriber and service level very often to specialist care. So the end result is that most mental health care was in psychiatric and teaching hospitals, and that community-based care, although available, was poorly integrated into the general health services and was very often run directly from the mental health coordinators in the regions. And finally, we examine the monitoring and evaluation processes. So these speak to both the availability and to the appropriate use. So there was no opportunity to examine appropriate use as there was no patient-linked data. However, there was some data from the District Health Information Management System, and this is more about the numbers of patients seen for various mental health conditions in all of the districts of Ghana, and information from regional mental health coordinators would be made available to the Mental Health Authority. However, the data was not adequate to give proper forecasting of medicine needs or of real-time availability, and as I've just said, it did not allow for assessing appropriate use of medicines. What it did allow us to do, though, is to make some kind of estimate of coverage in relation to the population in need. So in this table, in these figures, we have the numbers of people who are attended to in 2022 throughout the country for anxiety disorders, being just over 3,000, just over 6,000 for depression, 3,600 for bipolar disorder, just under 25,000 for schizophrenia, and then 11,000 for unspecified conditions, which would include very often neurodevelopmental and neurocognitive conditions, as well as some substance use conditions. The population in need was calculated using the One Health tool for the investment case, and I think there's quite a few documents around the investment case which are available on the Ghana Somubi Dwumadie website. And as you can see, compared to the population in need, the coverage that was obtained, and this is just the numbers that were attended to, so the actual coverage was 0.8% of people with anxiety, 1.8% of those with depression, 2% of those with bipolar disorder, and just under a quarter of those estimated to have schizophrenia. So very much in keeping with the 90% treatment gap that we keep hearing about. So what did we do after that is we examined the quantities of medicines procured for 2022, which could be used to treat these various conditions. And in theory, how many people could be treated for a year on a consensus-based dose every day for that year. So what we found is anxiety and depression would both be treated with either amitriptyline or fluoxetine. We used a dose of 75 milligrams at night for amitriptyline and one of 20 milligrams a day for fluoxetine. And we found that almost 300,000 CDs, enough medicines had been procured of amitriptyline or fluoxetine to treat just under 2,000 people for a year at those doses with either amitriptyline or fluoxetine. So 2,000 people, maybe not even a quarter of the numbers of people who are actually attended to in the clinics with those conditions, meaning that by far the majority of people who are attended to procured medicines out of their own pockets privately. With bipolar disorder, you can't see the figure, but we found that 1,500 people may be treated with either one of these mood stabilizers at a predetermined dose. So, for example, if lithium carbonate was given at a dose of 450 milligrams a night for 1 year, 8 people could have been treated. With carbamazepine, I think we used 200 milligrams twice a day. And then out of 310,000 CDs on carbamazepine, it would allow for the treatment of 1,300 people. So this 1,500 people would be that they would only be on this monotherapy at this dose for a whole year. So it's clearly an underestimate of what you can get for your money with these tablets. We didn't include sodium valproate in this table because it was procured in 2021 and it was procured in quite a large quantity, which was carried over for the 2 years. So what we've tried to do here is not an accurate estimate, but just to try and get some idea of who could we treat for the medicines that we buy at a basic dose. And essentially we found maybe half of those with bipolar disorder could have been treated with a mood stabilizer for a year. For psychotic disorders, and bearing in mind that this would overlap perhaps with bipolar disorder, but if looking at chronic psychotic illness or just making an assumption that all antipsychotics would be used for the schizophrenia patients, we found that enough medicines were procured to treat just over 13,000 people with a chronic psychotic disorder if each person was only given one medication at a minimum dose. We did try and accommodate variations of severity and patients, and conditions. So we used, for clozapine, we used 300 milligrams at night. So enough clozapine was procured to cover 9 people with 300 milligrams a night of clozapine for 1 year. Whereas for paliperidone, we gave ourselves a range of doses. And we said if, for example, somebody was stabilized on 75 milligrams a month, so you're purchasing your 75 milligram ampules, 10 people could be treated. But just take note that that is using 182,000 CDs to treat 10 people for 1 year at 75 milligrams a month. And if we can see from which other long-acting injectable was fluphenazine, long-acting injection, well, just under 400,000 CDs. So just over double 182, but you could treat 2,700 people for 1 year at 25 milligrams a month. So this is the impact of the incredibly high cost of medicine, which simply eats away at the budget, and you can hardly treat anybody. So what did we have to discuss? And the first thing is obviously how much can we spend? And we haven't got an answer for that, but it is really determined as a percentage of GDP. There, again, is quite a lot in the documents on the investment case. I think the proposal has been that 1% of total government spending could be allocated to mental health, but then not all of that would go onto psychotropic medicines. In fact, a small proportion of it would go on psychotropic medicines because the medicines form part of the package of care, which should be biopsychosocial and should include various social support and psychotherapies, as well as inpatient hospital care. So the budget that's available is dependent on the economy. It's dependent on the financing strategy of the National Health Insurance System, and it has to be sustainable. And so this puts enormous pressure onto choosing those medicines. We're back again now to selection of medicines. So what medicines could we afford? And this perhaps is where we spent a lot of time. Well, it's not perhaps, this is definitely where we spent a lot of time with the stakeholders, is discussing what can we cut out? What should we prioritize? And this is probably the most painful part. It's really difficult to narrow these down to what can be afforded. Then the third one is how many people can we treat? So even if we narrow them down, we will not make much of an indentation in that treatment gap. And the conclusion is that we probably should be estimating the coverage at what we are treating, so that extremely low coverage is the realistic coverage at the moment, and actually does also reflect the numbers presenting for treatment and the demand for care. So it's not unrealistic to estimate the medications that we need according to the demand for care, rather than according to the actual population in need. And to realize that it's going to be a very slow and progressive process to close that treatment gap. So the implications of inclusion in the National Health Insurance Scheme are firstly that the range of medicines has to be narrowed down considerably. However, the advantages of that include that the medicines will be procured and supplied as essential medicines, that there will be routine data collection as part of the National Health Insurance Scheme, that it allows for the development of person-centered outcomes and the monitoring of care according to the goal of treatment, and it begins a dynamic and evolutionary process whereby, hopefully over time, we can improve the quality of care and improve the range of medicines that are available in the benefits package. So in summary, there's a massive mental health treatment gap in Ghana of over 90%. Some of this is related to a low demand for care, as well as inaccessibility of quality care. There's parallel financing, procurement and supply chain processes with poor integration of mental health care into general health services. And there's weak monitoring and evaluation systems, but the potential of including mental health in the NHIS benefits package, although it might not please everybody, offers opportunity to strengthen integration, reduce stigma, improve monitoring, evaluation, and quality of care. And with that, I'd like to thank you all very much for listening, and we're open to any questions.
Thank you very much, Leslie, for that brilliant presentation. It must have been difficult to put together 4 years of work in a 20 minutes presentation, actually. Thank you so much. I think you have basically summarized what happened. If anyone has questions, I would encourage you to use the Q&A function on your device. If you have any questions for Leslie or about the presentation. So, Leslie, yes, it's good to see you again. After our last meeting, yes, in July this year, I think on our last workshop. One of the methods used in the work we did was stakeholder consultations. How useful do you think these consultations are when it comes to, when it came to addressing the barriers to psychotropic medicine access?
I think they were extremely useful. In fact, I would say that that's a major contribution that Ghana Somubi Dwumadie was able to make is providing that venue where everybody could come together. And we saw quite an interesting progression in the quality of those stakeholder consultations. The very first one in December 2020, I seem to remember there was a fair amount of hostility in the room, quite brittle discussions, and a little bit of an us versus them atmosphere. I don't know if you'd agree with me, but that was my experience. And we had people from pharmacy, clinicians, the Mental Health Authority, people from the Ministry of Health, and the National Health Insurance Authority were the main stakeholders there, as well as your advocacy groups. And it's such a hard thing to try and find a balance for everybody to move forward. And that for me is what we managed to do, at least in getting people onto the same page of realizing the necessity of this. So to me, they were exciting, the stakeholder consultations, and extremely valuable. We still need more stakeholder activity. We definitely need a role for the mental health advocacy groups. Even with all the negotiations that have taken place, to my understanding, they still haven't announced the actual package that's available on that National Health Insurance Scheme. So we've got a promise that it will be covered, been out in the press that it will be covered, but that final package is not yet announced. So that activity from stakeholders is so important. And I think, back with you.
Thank you. Thank you very much. And then looking at the proposed medicines for the National Health Insurance list, do you think some of the stakeholder engagements helped in narrowing down the list of medicines, psychotropic medicines that needed to be procured?
So I think what the stakeholder engagement did is it helped to soften the blow that it will be narrowed down, and help to get that sort of realization that actually this is the choice that we've got. And I think what really helped is to see the impact of expensive medicines on the budget. So that exercise that we did of how much we could procure and how does that translate into how many people could actually be treated and what is available in terms of the funding. I think that perhaps was the turning point for both clinicians and the user advocacy groups in accepting that we can't have everything that we want. It's just simply not possible. So that's where I feel it, and I think it was well worth that time. I think it's much harder to accept if it's just being handed down to you from some funder or government minister. This is what you're getting, and that's it, and that top-down approach. Whereas here we had quite a long process of working it out for ourselves and what could or couldn't be acceptable to us. Yeah. Don't know if that answers the question, Fidelita. So.
Yes, that's definitely does answer the question. And as you said, at that workshop, I think that was in 2023, the last two the workshops we had in 2023, where we got the prescribers, the clinicians, the pharmacists to actually sit down and look at what we could afford. Part of the complaint was, this is what is bought for us. We didn't decide. But when we all sat down to actually look at what we could afford on the and then the amount of money we had and the number of patients we had to treat. Yes, I think we all agreed that we needed innovative, more modern medicines, but on our daily budgets, on the government budget, we could not afford to do that. So yes, some people might be able to afford that. So that could be available for those who can procure on their own, those who can support it. But for the majority of people, we needed to look at fewer medicines to be able to procure larger quantities to make it available for everyone. Yes, that really was helpful. So looking at the Ghana situation, and I know you are involved in the medicine selection process in South Africa, and you are also involved with the Essential Medicines List Committee. Are there any similarities or are there any lessons Ghana can learn from South Africa?
Yeah. So I think we actually have a lot of similarities. So, South Africa is often, it's viewed as an upper middle income country. So we sometimes think we've got a better GDP perhaps, but we've got such a high level of inequity that when we're looking at the public sector and the uninsured population, the issues are very similar. We have an absolutely enormous treatment gap in the public health sector, which is 85% of our population who access that sector, and it's well over 90% again for mental illness. We've just done an analysis of the medicines we're procuring, and we found that it's extremely high. And Shidalicha, I just want to stop there because we've got a few questions. But in fact, before we go to the questions, the other major similarity that I felt was how we don't always have reliable suppliers. So even when somebody might bid for tender, they might not be able to supply. And the other problem is that the industry sometimes will withdraw a product from the public sector. And for reasons we don't always understand, and we've got to find ways of filling that gap. But there's now, I think, 5 questions, so let's go through those, shall we?
Yes, there's a question here actually about, did you explore other reasons for the huge gap in the unmedicated part apart from cost? This comes from JC Ofori. He wants to know whether we explored other reasons for the huge gap in the unmedicated apart from cost.
Okay, so in this particular project, we didn't really explore the reasons for the treatment gap. We accepted it kind of as what had been shown to us from previous research from the WHO Atlas as well. Although when we looked at and examined the system, I think we did feel that the community-based care, although it was present, because it's not integrated into general health services, might be contributing to the treatment gap, that lack of integration, the high stigmatization of mental health care, as well as the perhaps different ways of understanding mental illness, and therefore not necessarily attributing it to something that should be cared for within a westernized health system. So I think those are several major reasons for this high treatment gap. I don't know if that answers those questions, Jessie. Fidelicia?
Right. Yes, there's another question from Jones, and he wants to know, let me read what he says. He says, thank you very much for the work you are doing to support mental health in Ghana. I have been in the level community pharmacy for a while now, and these barriers cannot be overemphasized. However, I think it is getting better now than before. The challenge of late is some medicines arriving late and close to expiry. Bringing in the National Health Insurance Scheme will be a step in the right direction to reduce this challenge. Then he wants to know whether will all psychotropics be on the NHIS or some, or only some. That is what he wants to know.
Okay, so Jones, thank you very much for that question and for the work that you're doing in the community. And I'm sure that the barriers are quite immense. So we really believe that getting coverage by the NHIS is the way forward. But we won't be getting nearly all psychotropic medicines on the NHIS. It will be quite a restricted list of medicines. We can't announce them now because it has to be announced by the National Health Insurance Authority, and that's what we're waiting for. So what we've tried to cover here is the reasons behind that restricted list. One of the big reasons is actually to make sure that we can have a sustainable supply. So if you try to have a massive range of medicines, or not massive actually, but the current range of medicines and the STGs, if you wanted to have all of those covered by the NHIS, you might not get guaranteed supply from the industry. And that's because your quantities of each medicine are quite small. So it's better to narrow it down, have larger quantities of the medicines that will be covered, and have a more reliable, guaranteed supply from the industry, which is more in the industry's interest to supply medicines when there's a reasonable quantity and they know that there's going to be repeated use of those medicines. I hope that sort of explains that. Then, of course, the next step will be that the medicines would, once they're covered by NHIS, that the procurement cycle should follow that of other essential medicines. And the distribution should follow that of all other essential medicines for general medical conditions as well. So this idea that medicines arrive late, that you might get donor stock which is expiring, all of those sort of problems shouldn't happen with the NHIS medicines. Thank you.
Thank you very much, Leslie. I think Ernest Tope would like, says we would very much appreciate the opportunity to have some discussions on the possible strategies. Well, I don't think this is a question. So Ernest, I think if you could reach out to Professor Robertson and the rest of us here, we'll be happy to discuss the possible strategies with you. I'm not sure we can do that at this session. I have a question.
Let me interrupt, Fidelita, and I'm going to emphasize it yet again. The main strategy right now, so that we can start moving forward, is to get NHIA to announce the package of care. I think that's the top of the list of the strategies. Then there's a whole host of the other strategies of getting the supplies more streamlined, integrating donor stock with procured stock, getting real-time knowledge of what's available at regional medical stores, transferring medicines from one facility to another should one facility have too much stock, all those issues. But our top priority is for the National Health Insurance Authority to announce that package and to get that kick-started. Would that be the best strategy? Fidelita, I don't know.
Yes, looking at it, I think the current situation, getting it onto the mental health conditions covered by the National Health Insurance Scheme would improve access to a lot of people, especially in the rural areas. Though mental health care is free to the patient at the point of care, which includes medications, because of the funding gap, medications are not available, even care sometimes, so patients have to pay out of pocket. And of course, where out of pocket payments comes in, it reduces the number of people who can access some of these medications. So if they are available on the NHIS, the patient will definitely not have to pay out of pocket, because they will be given the medications and to be, the facilities will be reimbursed. So they would also be interested in making sure that the medications are available for them to continue to provide care. Yes. And then again, when it comes to the National Health Insurance Scheme, they are not, from the understanding, they are not covering all mental health conditions. They are looking at covering 4 of the common or the top 4 mental health conditions, which are anxiety, depression, schizophrenia, and bipolar disorder. And then, though they are using the standard treatment guidelines to see what medications are used for those conditions, they would also do their studies and then we have proposed a list of medications that we think should be used to manage those conditions. But then the NHIS also do something with an insurance policy after all. So they will also do their studies and then finally come up with a list of medicines that they think should be used. So yes, not all psychotropic medicines are definitely going to be on the NHIS list if NHIS decides to cover the mental health conditions. But definitely some of the most commonly used ones will be on that list. That should make life easier for most of our clients in Igbo. There's a comment from NST. He says, this is highly recommendable intervention in our mental health care system, given the magnitude of the challenges it has been embroiled in for years, and the increasing mental health cases for various reasons. The concern from FOBAC's perspective, however, is the pressing need for other complementary measures to manage the population of inmates at various treatment centers in a manner that helps protect their human dignity.
So I think, Fidelisha, I'm just wondering with Ernest's comment here about this is the dignity of people while they are at inpatient centers, I assume, yes, or in an institution. And that I think is largely addressed through two of the other webinars. Well, the one webinar on the tribunal, I'm assuming, and maybe help us here, Lila, but perhaps the one on the district mental health services. Because if we were to improve the community-based care and the district level care, we would hope that we would have fewer people requiring institutional care, standalone psychiatric hospital care, which tends to be undignified by its very nature, just because you've locked away from society for, even if it's just for a few months or something, it just carries so much stigma. But I think the tribunal is there to help to protect the dignity of people, and in traditional health practitioner centers as well. Is that right?
Yes.
Yes.
Let me cut in. There's a question here that we missed. I think it came in earlier from Emmanuel Bote. It says, with the current state of NHIS payment of several months of arrears owed to the suppliers of pharmaceuticals in the general care setting, can we be certain that putting psychotherapeutics on the list would increase access? I'm afraid that might have to be the last question we can take, as we are running out of time. So Leslie, do you have any comment about that?
What I'll do is I'll type an answer to the other question for you. So I'll put it in the Q&A.
Thank you.
Yeah. Okay, so just this was for Ernest. Please do register for the other webinar, especially the one on the tribunal. All right, so this is about the NHIS payment of several months of arrears owed to the suppliers of pharmaceuticals. Absolutely, Michael. And this would be from Emmanuel, is that right? No, we're well aware of these issues, and in actual fact, we kind of in March last year, we decided that for the time being we would stick with this discretionary budget that is being allocated each year. However, even though the NHIS has got all of these issues, including delayed payment to suppliers or facilities receiving delayed reimbursements, the advantage of having something under NHIS coverage is you have got one area for your advocacy efforts. It brings mental health care into the general health system, and all of these issues then require concerted advocacy. What's happening with the NHIS funding? Where are they being financed adequately? What's happening with their processes? Why are people out, not being reimbursed in time? Why are there problems in paying pharmaceutical suppliers? All of this becomes one concerted advocacy movement with mental health care included. Same with diabetes, same with hypertension, with all of the other chronic illnesses. So it doesn't necessarily mean that you're going to be certain you're going to get better access. What we're hoping for is that we're getting a better system and a more sustainable and reliable system that we can work with. Federica, I want to run with one other thing of the role of the FDA before we close. Yes. Actually, you've got two very, very quick questions. Specializing psychiatric pharmacy. We did touch on that in the last workshop, actually, didn't we?
Yes, we did.
I can't answer it, but we do want general pharmacists to be able to handle psychotropic medication. We don't just want them to be pushed across to a specialty, which is a standalone specialty. Although the advantage of having a specialized program, I don't know if it's happening yet in pharmacy training.
Yes, the Ghana College of Pharmacists is offering a specialty in clinical pharmacy, and the psychiatric option is there. We currently have some pharmacists undergoing training. We do have some clinical pharmacists, psychiatry specialists available in the country. But it's a new opportunity that has come at the college. So the numbers are not that many yet, but there are a lot of pharmacists who are practicing in psychiatry, the psychiatric units of the facilities. And we hope that as we progress, there will be more specialist psychiatric pharmacists. Yes. That is being developed as we speak.
And then, Federica, the next question's for you, not for me. The role of the FDA in quality control and cost neurogenerics from India. I mean, we did have FDA at the workshops. I think, yeah, I'm going to hand that one back to you.
Yeah, thank you, Leslie. I'm not sure how the FDA's role impacts on the cost, but any medicine that needs to be registered or supplied to be used in the country needs to be registered with the FDA, whether they are innovator brands or they are generics. So, of course, when you register with the FDA, there are certain processes they have to go through. I'm not that conversant. I can't speak for the FDA, but I think you have to provide data to do with, the test samples from they would visit the facility where the medicine is being made to make sure that it follows the GMPs. You have to provide the dossier on the medication. And so they'll do all those checks. And if it meets the standards, because I think for Ghana, it has to be according to British pharmacopoeia and maybe the US pharmacopoeia. So when it meets the standards, then you are registered. The product is registered for use in the country. Once you go through that, the rest is up to the market forces, I should say. But whether it impacts on the cost of the medications, I cannot really say because I have no idea how much that costs. And getting that process done cost. That's all I can say so far. I hope any further questions, FDA, you can contact FDA for assistance. Thank you. I think on that note, we are done with all the questions. There are no more questions in the chat, and I think we have actually passed our time. So I'd like to thank all participants for joining us. Thank you very much. For those who had some challenges, we apologize for the sound. I hope you were able to resolve it. There were some suggestions as to how to perhaps improve the sound quality at your end. So those who had that challenge, I hope they were able to take advantage of that. This is the fourth in a series of webinars from Ghana Somubi Dwumadie. There are 2 more webinars coming up. So if you are interested, you could, after the program, you will get the opportunity to log in and register for the other workshops. Actually, there will be a webinar. There will be a webinar tomorrow from the Mental Health Authority again, but this will be on the tribunals. So we'll be looking at those who are interested in the rights of patients who are receiving care. I'm hoping that webinar will answer your questions for you. Leslie, thanks so much for sharing your work and for answering the questions. I guess some of the questions put you on the spot. You had to answer for Ghana, but you did so well. And thanks, Laila and Co, for the support. I especially want to thank Somubi Dwumadie for the opportunity to share this work, and actually for the opportunity to meet, to be able to address the key barriers to psychotropic medicine access, actually. Yes, this Somubi Dwumadie has really given us the opportunity to meet with stakeholders and even to get this work done. I think we have come across something. We've had some next steps. We haven't had the opportunity to share all that with you, but I'm sure at the Somubi website, we can get some of that, the work that was done. We can be able to get more of it to read and then to find out more. Thank you so much for coming with us. Thank you, Laila, for hosting us. Bye, everyone.